looking at your laptop or mobile phones, it might fall into the cameras inside, therefore be aware of that one. Thank you. So shall we begin the recording? Okay. Good morning, everybody. Welcome to the Health and Wellbeing Board meeting on 9th March at 10 a.m. Our first spring meeting, wintry spring today, and there are quite a lot of action-packed items. There are 4 main items here, and then it is then followed by a closed development session. Okay, so we should be a little bit aware of the time. And before we start, let me welcome Jill O'Neill as the permanent director. She's a familiar face. Congratulations on being appointed to this post. And familiar face, of course, but she's in a new position as the public health director. Welcome to you. And also, I really appreciate the continuity you are going to provide and all the services you have provided so far. Thank you, Jill. Okay. So with the introductions set aside, let's go to the item number 1, apologies for absence.
So apologies from Suzanne Lamb, Councillors Patterson and Simpson, Claire Wheatley and Rob Mervyn.
Rob Mervyn. Okay, thank you. Disclosures of interest. I think it's all set aside. Is there anyone willing to disclose any particular interest? Please do so. I see nothing, so let's move on to item number 4. Director of Public Health Annual Report 2021-22, and that will be presented by, I think, Jill and also Kat together. Yeah, I think this is the last report our last director wrote, but nevertheless it's going to be presented by Jill. Thank you, Jill. Please, yes.
Chair. So everyone should have received a published copy for you this morning. We're really delighted that, to say that this is Liz's last report, and it's hopefully a really good legacy for her on such an important issue for us. Kat, who's been our lead author, is a registrar, training to be a consultant, so is going to be delivering the presentation. But there's been a number of people within the audience who've significantly contributed to the report. And just to note that all the pictures and case studies are clearly Northumberland specific, so it does hopefully have a real Northumberland flavour to the report, whilst a lot of the information is also national. So I'll hand over to Kat, who's got some slides, and then we can open up for comments and questions. Thank you.
Thanks, Jill. So as you'll know from previous reports, the nature of the Director of Public Health annual report is to comment on a local health issue for the community. And this year we've decided to focus on healthy weight within children. So why healthy weight? Well, we know healthy weight is incredibly important for lots of different aspects of physical health, mental health. So it's been associated with lower rates of mental illnesses such as anxiety and depression. And also more broadly, children who are a healthy weight are more likely to do better at school. Also economically, it will have a huge benefit. So we know that obesity remains a significant economic burden, and at the moment is the second largest economic burden on the NHS after smoking. So what is the picture currently in Northumberland? So when the report was written, we were using 2021 data, which showed that over a quarter, so 26% of reception children, so that's children aged 4 to 5, were either overweight or had developed obesity. And by year 6, so that when they're aged 10 to 11, this had almost doubled to about 40%. So almost half of our young children are not a healthy weight. And the figures for 21-22 have recently come out. So we do know that COVID had an effect, both in terms of a national trend of increasing obesity and also in the terms of the way it was measured. So not all schools could partake in the National Child Measurement Programme in the COVID years. However, post-COVID figures still show an increase, so a slight improvement, but still an increase on pre-pandemic levels. And these 3 graphics just show the demographic breakdown of these trends. So the one on the left shows that Overweight and obesity is more likely to affect boys, so the darker colour over girls, which is the purplish colour, particularly towards the severe obesity side of things. The graphic in the middle shows how Northumberland trends compare to national trends. So the black line is the national trend, and the coloured line is for our county. And we can see that we were improving, but at the moment we're roughly following the national trend, which, as you can see, has increased. And the graphic on the rightmost with all the blue boxes. So IMD stands for Index of Multiple Deprivation. So and the number 1 is the poorest 10% of our households in the country, and number 10 is the wealthiest. And the darker the blue, the higher the rates of obesity. So you can see clearly there that there's a great tie to inequalities and what we would call a social deprivation gradient. So the poorer households are disproportionately affected by obesity. What we really wanted to impress with this report is to move away from what has historically been quite an individual narrative around willpower and education and so on, to look at the wider environment that can lead to obesity and all the different barriers that exist in the settings where children are born, where they play, where they live, where they spend their time, and how we can address those barriers, looking at it from a broader social, environmental perspective. So these are some of the key barriers that we picked out that I will delve into in greater depth with each setting. I won't go into detail for all of these, you'll be pleased to hear, we won't have time, but I'll pick out a few key ones. So within the home, for example, portion sizes, we know portion sizes have gotten larger, and also that healthy food is less affordable and accessible than calorie-dense alternatives, particularly for poorer households. So we know that the poorest fifth of households within the UK have to spend almost half of their disposable income to eat healthily, whereas for the wealthiest fifth, that's only around 11%. So clearly a significant difference there. And also the impact of the cost of living crisis, amongst other things, has meant an increased use of food banks. Unfortunately, people relying on food banks to bridge gaps and for emergency food. And that means they have less choice and also are relying chronically on food that is usually higher in carbohydrates and sugar because of the nature of donations and also the kind of food that food banks stock to make sure supplies last. Another key thing I wanted to pull out here is breastfeeding rates. So very positively, breastfeeding rates have been increasing in Northumberland over the past 3 years. But we still remain below the national average. So nationally, it's about 49%, and we're currently at 42%. And we know that breastfeeding is incredibly protective, both for maternal obesity and also for infant obesity, especially if that's continued for a longer period, for over 6 months. I should also point out that on the slides I've highlighted where our current strengths are. For time reasons, I won't delve into those, but hopefully you can read more about those in the report as well. And I'll touch on that in our recommendations. So within our communities, takeaway culture is a big factor. We know that use of takeaways increased during the pandemic and that trend is continuing. And also advertising and promotions generally tends to fall disproportionately on unhealthy food. So multi-buy offers, buy one, get one free, etc. For far more on foods that are HFSS, so high in fat, salt and sugar. And there are also some key barriers to physical exercise, such as a lack of equipment, a lack of confidence. So, for example, if parents don't feel confident on a bike, they might not feel able to impart that to their family. And also a particular challenge in our county, because of its rurality, is that we're quite a car-dependent culture, and that can lead to a reduced kind of daily active travel. So we know that lots of schools are already going the extra mile to both work physical activity into the daily routine and also provide healthy and nutritious food. But there are some key barriers remaining. For example, the rise of in-work poverty means that there can be a gap between children who are eligible for something like free school meals and those who are actually receiving them. So we can have a cohort of children whose family might not be able to provide them with a healthy, nutritious packed lunch, who might have to resort to those kind of cheaper, calorie-dense alternatives. And we also know that physical activity decreases with age, particularly in adolescent girls. So looking at how we can build activity just into the everyday for children and how we can make it easier for them to travel to and from school by bike, by foot or by scooter. And finally, looking at healthcare. So because of the changing social picture around overweight and obesity, this can lead to a lack of recognition by both parents but also healthcare professionals. And we also know that, unfortunately, and I think because of this historically individual narrative, there is a lot of stigma around weight, both professional and personal, which can make it really difficult to both have the conversation and to address some of these barriers. What I would point out really positively is there's a wealth of data here. So the National Child Measurement Programme, where these statistics are pulled from, Northumberland has a really excellent engagement with that. So that's children measured at reception age and year 6 age. And we have excellent engagement. So there's a lot of data that can be used. It's just thinking about how we communicate and use that going forward. So we know that as a council, we're committed to tackling this issue. We've recently signed the Healthy Weight Declaration. We have the Joint Health and Wellbeing Strategy. And as you saw on some of the slides and hopefully in the report, there's a lot of excellent work already happening in terms of whole family programs, in terms of individual programs such as sessions teaching people how to cook with slow cookers and so on, or support with breastfeeding. So there's a lot of work already happening, and it's thinking about how we can build on that and expand that. So our recommendations, first and foremost, are the reframing of this approach away from an individual narrative which focuses on kind of willpower education to looking at this more widely across all the barriers I've mentioned. And with that, communicating and sharing good practice. So what can we learn from what is successful? What can we learn from what hasn't been so successful? And how can we expand that across our county? And collaboration is a key part of that, as well as collaborating with stakeholders who might previously have not been traditionally involved in this conversation. So, for example, looking at something like what we would call the commercial determinants of health. So how can we work with private companies or shops, etc., to look at some of these barriers? Underpinning that with our strategies, so we are currently developing a food insecurity plan and refreshing an existing physical activity plan as well. And that will include looking at access to green spaces, looking at how we make active travel easier and also more integrated into just the daily life. And as I've mentioned, there's a lot of data out there that we can use. So the NCMP data has really is very excellent. So how can we deliver that to the people who need it so that we can target areas and prioritise areas that need it most? Thank you very much. I'm happy to take any questions.
Thank you very much, Kat. Yes. Any questions? Yes, please.
Thank you, and thank you for a very, very comprehensive report with many practical suggestions and recommendations. But apologies for asking this question again. Well, apologies in some ways for asking this question again. You focus, all the areas you focus, one of them is on schools. And you mention the learning environment, energy drinks and so on, and healthy meals. And also in your recommendations, the top one, reframing our approach more widely at schools and so on. So, particularly for the secondary sector, where there are so many almost independent now schools, academies and so on, how effective has been your campaign in engaging with those schools who are no longer under the jurisdiction, etc., of the county council? Are they receptive to people going in and talking about energy drinks and so on? And just anecdotally, I know from experience, there's one high school which sells fizzy drinks in their PE area. Now, to me, that is not in keeping with this sort of approach. So how effective can you be with these almost independent academy schools?
Thanks for the question, and people in the audience might want to contribute as well if you're in schools on a day-to-day basis. I think the purpose of this report and why we wanted to bring it post-COVID is to reset and start the conversation again, because obviously there's been a lot of work undertaken prior to COVID around healthy schools and that engagement, and this is an opportunity for us to go back in and have those conversations, and we're really hopeful that the Healthy Weight Alliance will have a strong education component to that, and certainly when we've presented it internally with our executive team, Audrey Kingham is really keen to work with us on how we best have more specific conversations within our education sector. But I'll see if anyone else wants to add anything addition to that from the audience at all. No. Okay.
Any follow-up?
I just...
Hi, my name's Sam Anderson. I'm one of the service managers from the 0 to 19 team. Thank you very much. That report's very comprehensive. Just to answer, or just to give some context, as part of our some of our new model will be to work more collaboratively with schools within our public health pillar, which we will be presenting today slightly. We will be going in and offering 3 priority areas, and that could be something that we could offer schools to talk about healthy lifestyles, etc. So we're hoping that we will be able to contribute to schools, whether it's independent or whether it's under the council jurisdiction.
Any other questions?
We described the hot food takeaway policy by the council, and I was pretty impressed by the first bullet, which says that we will not allow, the council will not allow any hot food takeaway if there are more than 35% of the year 6 people have overweight and obesity status. So that is really a good intervention to control commercial determinants, as we call. Are there any examples or instances of council saying no to opening a hot food takeaway?
So across other councils, absolutely there are, even Newcastle recently and in Durham as well, they have been able to apply their policy. We have checked locally, and we haven't had the opportunity as yet to test that policy because we haven't had subsequent applications within those zones. But that is the whole purpose of the policy, to give us that robust structure to be able to give an evidence-based narrative as to why we would choose to say no thank you to those establishments coming within those zones. Zoe, I don't know if you want to say any more on that.
Yeah, as I say, it's early days, so we've had this policy been in place for just short of a year. So yes, we're yet to see any hot food takeaway applications to be able to determine how strong the policy is. But as Jill says, it is effective in other organisations, in other neighbouring authorities. So we hope that it will hold.
Yeah.
Yeah.
So it was brought in 2018, is it? Is that correct?
Just March last year.
March last year. Okay, right.
It was brought in part of the working towards signing off the local plan, wasn't it? So that's probably why it's a 2018 date, but it just went live, as it were.
Okay, because I see 2018 in brackets, so
yeah.
that's why. Yeah, okay. Thank you. Yeah, I think, thank you very much. And I just noticed I missed item 2, which is about endorsing the minutes of the previous meeting. Can I sign off as the true record of the previous meeting held on 12th January? Okay, thank you very much. Thanks, Graham. I was reminded by my vice chair. Thank you very much. Okay, let's move on to the 5th item, which will be on 0 to 9 Growing Health Service Summary Report, and will be presented by Ashley Easton.
Hi everybody, I'm Ashley Easton. I'm the General Manager for the 0 to 19 service in Gateshead and Northumberland.
Hi, and I'm Sam Anderson. I introduced before. I'm one of the service managers for the 0 to 19 service in Northumberland.
Thank you for inviting us here today. We've come to present a summary report that was, requested from our partners, the commissioners. So we've come today just to present some highlights about the report and also to take some questions. So currently, as we speak, we're working through the transformation of a workforce into a 0 to 19 model. We hope to develop and deliver this service through taking on board skill mix, introducing new roles, to meet the key priorities of our partnership arrangements and support integration and collaboration with key stakeholders. We're also working towards integration into the family hub model. So the model is based on restructure changes which are influenced by experience and best practice. We hope the model will evolve and develop, responding to local need and national changes, and we hope to manage colleagues 0 to 19 across all of the Northumberland areas, using the thematic lead area to promote service transformation and improve quality. We have kind of thematic areas that we will work towards, so these will be quality and performance management, vulnerability, the Healthy Child Programme, Universal, our SEND offer, digital and service user experience. These will develop and evolve, and we will take on new thematic leads as the service develops. So this is our key contacts and structure. We are continuously working on this, and we will send this out to partners. Key names and mobile phones will go on this as it develops, but we are transitioning staff into the new service. So we have agreed 3 areas across Northumberland. So they will be North, Central, South East and Central West. We're in the process of recruiting 1.5 locality managers to give us some strength in the locality management area of the management team in Northumberland. The integrated management team are developing an action plan to support transition across into the new 0 to 19 model, and we will be looking at our strong offer around supporting staff health and wellbeing through what is the significant change and transition. We're looking to embed a single point of contact within our admin bases so that partners are able to contact us, progress our estate strategy, really work on our clear lines of communication and strengthen our relationships within the system, and really embed a strong, robust governance structure. So we've already moved forward with our recruitment. So we've got a clinical lead in post for emotional health and resilience. We've got our community anchor in post, and we've also got our community triage, and our project support officers have now started. Yesterday, we went into our new System 1 single unit. So for those that weren't aware previously, we had 4 separate modules on System 1. And as of yesterday, that was merged, and we now work into our new electronic record. So the Grow and Healthy service is currently delivered by the Healthy Child team. It is delivered, by a skill mix workforce, but this is led by specialist community public health nurses. It is also enhanced by clinical champions within the service and the thematic lead roles that we've popped in. So we have 5 core contacts. They are the antenatal new birth visit, 6 to 8 week, our 9 to 12 month, and our 2 to 2.5 year review. These are to be done at home and will, include a family health needs assessment and a home environment assessment tool. Within these contacts, what we would hope to see in our standards are an assessment of development, a review of growth monitoring, an assessment of maternal and paternal mood, and this includes signposting for fathers to partners within the system to support. But for mum, this will be the depression identification questions. Building on that will be the EPDS and the generalised anxiety disorder tool. We will then look at ongoing referrals to GPs or mental health services, but also for our service, this could be the delivery of 6 listening visits at home, almost talk and therapy, to sit and talk mums through anything that they feel they need, to work through. This is assessed at the beginning and assessed at the end as well, so we can mark progress or then go back and refer on to within the system. Within the contacts, we'll also be delivering general health promotion. So just some examples are healthy diet, home safety, dental health, positive attachment that includes play, signposting to children's centres or family hubs. Let's have another little look. for mum also, and we're looking at contraception, positive well-being, health promotion, healthy relationships, but also we're looking at support and isolation, so really supporting families to be able to engage in our family hub offer moving forward. From a recruitment perspective, we are in the process of doing Harrogate and District Foundations for staffing tools, which include OPA levels. So this is about drilling down into the workforce to look at demand and capacity and to make sure that we absolutely have the right resource to be able to deliver a really quality service. So that is ongoing at the moment, and that will, you know, really kind of enhance our recruitment drive. We are continuously recruiting. We know we have 5 Skiffin students qualifying in September, and we're working with those students. We want to keep, you know, our staff in Northumberland and really encourage staff to stay here and want to work with us. And we have been really, you know, lucky. We had 2 apprentice students that graduated this March now, and they will be staying with us. But also we are looking for the future. So we've got an education lead within our service, and we're working within the footprint to try and make sure that we are represented at recruitment events, that we are, you know, really presenting Northumberland as a really excellent place to come and work. We're doing that, you know, we had a live event 2 weeks ago on an evening, and we had 70 plus you know, prospective applicants at that live event, now represented Northumberland at that live event. So these are our key performance indicators. So as you can see, we've got our antenatal, new birth, 6 to 8 week, 12 month and 2 to 2.5 year. And you can see, you know, where we are in terms of a percentage.
So we have invested in our infant feeding pillar, previously known as the breastfeeding support area of the service. The infant feeding pillar is led by a Band 7 specialist nurse who will be looking at our action plan that we've got in place to lead the service going forward. We will be proactively supporting contacts postnatally, including the number of breastfeeding support groups across the county, and introduce a tiered approach to the support that we will be offering. We will be obviously building into the service the UNICEF standards. We recently, as a service, went through a progress review. We have maintained our gold accreditation, extremely proud of that, for the hard work that all of our staff have put in. There was one action identified, which is part of our action plan as a service, and that is to engage staff around infant feed and listening to them. As you can see below, that is our current contract data of breastfeeding support. As Ashley mentioned before, our previous school nursing team, as part of the new model, will be divided into 3 separate pillars. One will be the public health pillar, we will have an emotional health and resilience pillar, and we will have a safeguarding pillar. So this is the public health pillar. This pillar will have a set criteria for referral. The pillar will manage level 1 continence support, risk-taking behaviours, sexual health, healthy lifestyles and relationships in line with the family hub model, transition support, and targeted local health promotion in line with the public health calendar. We will also be offering school profiles to all schools in Northumberland. We will be asking for them to identify 3 key priorities in their school and working collaboratively with them to support them with their 3 key priorities. This support may be offered through digital delivery with some of our evidence-based digital delivery programmes that we have, or targeted delivery into schools. We will also be signposting within the service or within the system if other services are better placed to be offering that support. The public health pillar will also be delivering the NCMP, which we've already heard today from the Healthy Weight report. This year we will be providing a whole system approach, as Northumberland have done previously. But from June time, we'll be looking at the NCMP running throughout the whole academic year from September onwards. And we have appointed 2 screeners in interviewing this week for an additional screener, and their role and responsibility will be to plan and implement the NCMP across Northumberland. Post-COVID, the service of the 5 to 19 team have seen a significant surge in referrals for children experiencing low-level anxiety and low mood. Other services have also voiced similar concerns. And all our referrals are screened and triaged by a public health school nurse within 2 working days. The process provides a timely response to any safeguarding concerns and any high-level emotional health needs. The public health school nursing team develop a safety plan ensuring that parents and carers are fully informed around any decisions to be taken should the child's presentation deteriorate. A letter is also sent out to parents and carers advising that the service is operating a waiting list at present and how to contact the service if needed, if it is not a priority referral. The letter includes a list of resources for parents, carers and the child to access, such as COOTH, Young Minds and Partners. An action plan is in place, as discussed before, to address and reduce our current waiting lists within the service. This is being led by all service managers and includes safe delegation to the skill mix team and the use of NHSP, which is a bank service for nurses. The emotional health and resilience pillar, so we're working in partnership to develop a service criteria that supports early intervention and level 1 support. We're developing an integrated offer for relaxed kids. The service managers are working with partners on the development of a sensory pathway, working with education to ensure that children and young people with possible neurodiversity have access to the service they require. We continue to work on our long-term plan to appoint 4 children's psychological wellbeing practitioners into the service. At present, we have staff who are undertaking additional training. 3 staff have places for the Enhanced Evidence-Based Practice programme at Northumbria University, which commences this month. Our safeguarding pillar. So we have appointed a Band 7 safeguarding clinical lead post. Their role is to include face-to-face support for more complex case management cases. They will be vital in supporting external and internal staff into this new pillar. We are currently working through recruitment into the strategy nurse posts at present, and some strategy nurses have already started this week. There's a Band 5 staff nurse and children lived experience practitioners who will be working with children to really capture the voice of the child. The safeguarding team have introduced introduction packs and a competency framework for all of the staff that are moving into the pillar or being recently appointed. They are completing self-assessments on all staff and offering shadowing opportunity for all staff in the pillar. The team have embedded a Signs of Safety training package for staff and a full, as mentioned, a full induction pack. And as you can see, that is our current compliance at the moment as a service for level 3 training, safeguarding supervision and all responses through our front door. Within the new model, we've... It's all right. Within the new model, we've got some innovative roles which we've developed. One role is the community anchor. This role objectives include scoping the various community projects and initiatives across Northumberland. Community profiling work alongside the Family Hub and Early Help project team. Support and develop of the Family Hub model, and we'll link into the work streams that we are working within the Family Hubs. The community anchor will be required to undertake some community asset training alongside colleagues in the local authority. This will also be cascaded across our 0 to 19 service. We have a community triage nurse. They will work into the Early Help Hub for 3 days a week. Their role will be to support the flow of referrals across the system, representing the public health pillar and emotional health pillar. The role will be pivotal in providing a timely response to referrals, ensuring agreed waiting lists are adhered to. They will also signpost referrals to partners deemed more suitable to meet the needs. of the service user. And the project support officer role. This role includes responsibility for implementing the transformation of our digital platform. The role supports the mobilisation, continuous improvement within the digital offer and supporting 0 to 19 practitioners with training and development. We are developing our social media offer to include health promotion TikTok messages. We are ready to launch, actually we have just launched our stage 2 of the Healthy Child app, which can be downloaded. And this will include our virtual nurse offer, or known as Health Chat offer.
So this is our estate strategy. We have had our first move, which has been in the West, just to really reinforce it in terms of clinical activity out there in you know, the GP practices. The clinical activity will continue. We have sent out our GP standard this week because we really want to, you know, work in partnership with the GPs, strengthen our relationship, and it's absolutely about, you know, continuing to develop, build relationships. This estate strategy is about a 0 to 19 in infrastructure around our staff to be able to go out there and do their clinical work, and in the background have a single point of contact that is manned by admin staff, so that they aren't, you know, we've got one contact number for everybody. We work through this estate strategy. As I say, we've only had one movement, and that is in the West. But what we are doing is, as the moves are, you know, pending, we're sending out communications to partners around that move. So just very quickly, because I appreciate time's, you know, running on. We've agreed our geographical areas. We're increasing capacity into our management team to be able to really strengthen the transition. We've got staff appointed into our clinical lead roles. We've got our single point of contact. On a real positive note, the public health pillar have been awarded Team of the Month, and it was in December 2022, not February 23. But also really positively, we are recruiting into posts, and it's Northumberland staff or staff that are relocating into Northumberland that are approaching us to come and work as part of the 0 to 19 team in Northumberland. So I think that's a real strength. So our challenges, we're really working on our staff health and wellbeing offer. We appreciate the impact of change and transition on the workforce. So we're really trying to strengthen our offer and engage, you know, with local opportunities to promote that for staff. We will continue to monitor the referrals into our 5 to 19 and emotional health and resilience report on the impact, and work, you know, in the partnership on the action plan. We're going to be embedding some local performance panels, and these will be in the 3 areas, and that is about really looking at challenging areas, but also it's about celebrating success, what works in that particular area of Northumberland, and how do we share that, how do we cascade that. We will be working towards an enhanced parent pathway that will be co-created with our partners, and this is about being able to, you know, step up our support outside of those 5 mandated contacts and what is locally needed within Northumberland to support parents. And then, you know, we're very, very excited to be working as part of the Family Hubs offer, improving integration. We are absolutely, you know, really working with the staff to, you know, cascade that vision and embrace connections and maximise collaborative opportunities across Northumberland. Thank you.
Thank you. Thank you very much.
Thank you.
Report. Any questions? Yes, please, Grant.
Not so much a question, more of a statement. Members may remember at the last meeting of the board, I challenged myself, I challenged my service, and I suppose by default I challenged other members of the board to consider what you take away from here, and what you take away from here and how you build systems and processes to deliver against the things that we commit to doing. Since that time, Sam has met with our team, and it's just to give you some update that we are now talking very similar language, and we're knowing how our systems and processes are joining up. You talked about the home environment assessment tool. I think it's conducted during home visits. That didn't include any elements of fire safety. So we are now developing a bespoke presentation that we will design for the Harrogate District team of about 140 staff, is that right? Just to increase their awareness of what our offering is, for them to think a little bit about fire safety when they're in the homes. From that then allows our staff, when they are having that opportunity in a home, to talk about the wider issues beyond fire that I spoke about a few months ago. We are also developing our referral form to adapt it so that it can actually sit in Harrogate and District's systems when they're making referrals. And just finally, we're scoping out some work to potentially utilise Hexham Community Fire Station for a weekly infant wellbeing clinic with a site visit that's happening on the 20th of March. So it's just really a celebration of the reason I think I was co-opted onto the board, and hopefully an example of how, if we co-produce, we'll develop even more resilience. So thank you.
Yes, not a question, more a comment, if I may. Thanks very much for a very comprehensive report, which covers the breadth and depth of the excellent work you're doing. But I noticed that you were awarded Team of the Month somewhere. You know, from what you've said and the ambition which you have, that seems to be a well-deserved recognition of what you were doing, because it seems as if you are actually making a difference. So that's great, and more power to your elbow.
Thank you. Really, thank you.
Sorry, I didn't mean to make it ping. Thank you. The first part of your report, I would echo David's part, a lot of information and a reflection of management of the service, which I can see a lot of thought has gone into. And I was writing down questions around integration and development and culture, because I wasn't getting a sense of that until I saw the last 3 slides. And that actually pleased me greatly to see that, and you've written about the community anchor, that post feels like that's almost one of the most important things around innovation and integration. I would just make a further plea. Primary care and GPs don't get much mention there, but they see themselves as integral to supporting families as well. And I think with some of these changes about moving to family hubs and that piece of work, doing our very best to make sure that we all move in that direction around families together. So I would just say, we've got some primary care people in the room today. Please, let's just make sure that we do as much as we can to cement that relationship.
I mean, I think, you know, I don't want to speak on John's behalf, but we're currently working, you know, at some stakeholder events and partnership events where we can come out face-to-face, meet members of the Primary Care Trust, you know, and really start, and really it's about strengthening our relationship and partnership working and in working together. You know, we really want to work hard to, you know, maintain our strong links with our GPs and strengthen them, if I'm honest. So we're really, you know, absolutely committed and dedicated to absolutely developing and strengthening those relationships. And if there are gaps, you know, my email address is there, my phone number's there, please give me a ring.
Yes, it was just to come back on that point and your point, Graham. I'm John Lawler. I'm one of the public health consultants in Northumberland County Council, and I work closely with the 0 to 19 service, and we've worked closely together to develop this service model and the vision going forwards. I think you're absolutely right. There is a lot of integration which is embedded within the service, and that's particularly being done through family hubs and the family hub development. I know there's been some effort to co-opt primary care representatives onto the family hubs work streams and the implementation group, because they are, as you say, an absolutely core component of that offer. And I think that community anchor role is absolutely fundamental, and it aligns really well with the inequalities strategy for Northumberland and the emphasis on capitalising on community assets as well.
I really just want to say thank you very much to Harrogate for all of the innovative work and the hard work and determination, because I know it's not easy to do that level of change process. And just to echo some of the comments around integration and collaborative working, a number of us have been around a collaboration integration group, and I think we're all under the same mindset that it doesn't matter what lanyard we wear around our necks, it's about that think child and think family approach. And I think as long as we've all got that same ethos, then we're on the right direction of travel. And I think family hubs is the the perfect vehicle to be able to take that forward for us, making sure we are fully talking and feeling like we're connected into the likes of primary care as well. So thank you for that level of detail that you've shared with us today.
I'm Graham Rice, the Service Director for Children's Social Care. Just to reinforce the points around the Family Hub developments, and we've had papers here before, you know, the fact that we've got trailblazer status in Northumberland, one of only 14 local authorities that have got that funding, I think recognises the contributions of all partners to developing the Family Hub model. I think the question you've got is perhaps a bit more granular, just talking about, I think covers the public health and also the safeguarding pillar, but just about the engagement of fathers and how that's recorded and pursued in terms of that from both those aspects. Just a bit more information about that would be very helpful.
I mean, we've got a family health needs assessment which has a a whole section on dads, including their emotional health promotion, what their health needs are, because we know that is a contributory factor into the whole the family dynamics. But also from a dad perspective, we're having conversations locally in Northumberland with the staff, because it's about having that direct conversation with dad. Is it okay if we open a record? Can we record that down as an episode of care? So it's about changing it around a little bit, because historically we haven't routinely held information on dads, but it's about being really honest with dads as well and getting that consent, and then being able to capture information so we can share it with primary care that we've had that contact as well.
Good report, full of information. In fact, I read most of these reports come to me, and it was a bit hard going at the beginning, but it made sense as I went along. So regarding the waiting times, you admit in page 54 that waiting times need to be reduced in PHS and waiting times. So do you have any target time period to move towards something like that?
We have been working with partners in some meetings. I think we've been very open and honest about we do have a waiting list in place at the moment. As part of our action plan, we especially around the emotional health and resilience pillar, we've invested in the service training, which is actually occurring as we speak, to look at maybe some referrals that don't really hit the criteria for ourselves, but actually how we can support those children going forward. So we're going to be doing facilitating sessions such as Relax Kids, which is an emotional wellbeing session for children to support them, and then signpost children onto more appropriate agencies if that is required. So we do have an action plan on how to reduce the waiting lists across the service.
Okay. Thank you. I really appreciate, because you were introducing some self-criticism, examination and reflection, and then you are saying it. We are achieving, trying to reduce something. So that's really good thing. So thank you very much for the report. We can move on. Sorry, Graham, please.
Just a very brief report, I guess, on the waiting times. That also is subject to scrutiny through the Safeguarding Partnership as well, who do need reassurance about that. So that's been answered through that process as well, just for information for this board.
Health inequalities funding allocation across the Northeast and North Cumbria Integrated ICB. I think it's going to be presented by Jill. Please, Jill.
Thanks, Chair, and I'm mindful of time for us as well, so I'll keep it brief unless people have got specific questions. So this paper is for awareness raising as much as anything for the board, and it's a real positive marker, I believe, around the closer alignment of resources for preventative work in relation to tackling inequalities. The paper describes how the 13 million from the North East and North Cumbria ICB will be invested at both regional level and at the level of place over the coming 3 years. Not going to walk you through the detail of the report. Hopefully it's relatively self-explanatory, but just to highlight, there are 11 areas of spend overall, all of which are highly evidence-based interventions, or if they are newer and innovative, have got wrapped around evaluation in place. And they're all in relation to tackling the healthcare, public health inequalities from the perspective of it being NHS funding. So as I say, each area has got monitoring in place. They're either already in training, it's about top-up monies, or it's about bringing in interventions that we haven't been able to fund to date. So that's all I really wanted to say, unless there's any specific questions on any of the 11 areas.
So we all seem to be happy with this one, yeah? I think we can move on, correct? Leslie, is there any other action point in that one? No comments?
Just to accept the
Yeah,
report.
that's it, yeah. Thank you. No more questions to Jill. The experience to accessing primary health care, I think presentation from Pamela Phelps.
Thank you, Chair. Thank you to you all. My name is Pamela Phelps. I'm the Senior Head of Commissioning for Primary Care with Northumberland Integrated Care Board in Northumberland. And my colleague Hilary.
Hi, I'm Hilary Snowden, Executive Officer for Northumberland LMC.
So we have presented to the Overview and Scrutiny Committee in the past about general practice and access to general practice and about the patient experience. And we thought we'd come back and just talk about what we're doing post-COVID, access to general practice, and give you a bit of context and overview as to what's happening by way of recovery and also planning. So just as a bit of context around general practice in Northumberland, we currently have 36 practices, which is a reduction of 10 in the last 10 years. So the number of patients in the last 10 years has risen by 12,000, but the weighted element of that population across Northumberland registered with a general practice has increased by 30,000. So what that means is the complexities of the patients based on the actual numbers versus how that converts into workload, interface, complexities and need. We are seeing more complexities of patients, more time and capacity required to support families. And in the last 10 years, it's been around 30,000 increase in that weighted population based on need. The rest of this slide gives an overview of the workforce, the staff, the roles, and also the age profile within the population of Northumberland seeking support from their primary care services and general practices. We have seen an increase in employed staff numbers across general practice, which is a really positive thing. We have seen a decrease in GP numbers, albeit small and in comparison to other parts of the region. That's mainly due, the increase in employed staff is mainly due to the primary care network, direct enhanced service and the additional roles reimbursement scheme. So we've seen an increase of 130 workload and workforce and staff in our practices. And that goes some way to describe the shift in reliance on just GPs to see patients and families and carers within primary care, but about that holistic need. It's about pharmacies, physiotherapists, and how we build a primary healthcare team, and we just don't rely fully on everyone seeing a GP. It's about getting what you need and the services and support from a whole team in general practice. By way of a little bit of context as well, we've done an overview of the primary care estate and premises, and this is general practice, main sites and branch surgeries. So 75% of the general practice estate was built more than 30 years ago, and we do have 10 surgeries needing an increase to be increased by 50%, and this is all based on the numbers of patients that need to be seen, how we run that through some number crunching and work out what capacity we need to start to provide in the appointments and in the estate to align with services such as the 0-19 service, mental health and others. So as by way of a bit of a context and update on the appointments in general practice. So we are seeing a marked increase in the number of appointments even from before COVID. So before the pandemic, we are doing more appointments now, and in the last 12 months we've seen 2.25 million appointments available in general practice across the county. The other boxes give you some context as to the amount seen face-to-face. So coming out of COVID, we are seeing that rise again significantly. And the largest proportion of those seen face-to-face is with a GP. We're seeing home visits begin to come out of that lull from the pandemic, and that face-to-face and getting out to communities is really back up into the 1600s there from lower numbers previously. 82% of appointments are seen within 2 weeks when patients request access to a general practice. And we're seeing the range per 1,000 patients across all our practices in Northumberland is starting to increase. There are some variances there, and that's mainly due to the demographic, the rurality, the deprived areas in the southeast corner. We are seeing a range, but we are monitoring that, and we are working with practices very closely. What I must say about this is the national data set for access to general practice is using the GP access data, and it's called GPAD in short. Now, looking at this information, it doesn't count every contact or every appointment, and the national team are beginning to look at the data set for general practice. So, for example, it doesn't count appointments where a primary care network where the practices work together in hubs deliver services. It doesn't count those appointments currently. And some of the workforce employed by the primary care networks, which is the grouping of practices, it doesn't count all of their appointments. So the 2.2 million appointments over the last year is a proportion of what was made available. The other count on these numbers is that it counts appointments booked. It doesn't account the capacity that was in practices in the first instance. So alongside seeing a great increase in the number of appointments being made available and the workforce changes, we have got to focus on what the strategic plans are around enabling general practice to remain stable and remain there for their communities and their populations. And I think that integration agenda we talked about before is really key. So it's how do general practice work with other services to make sure families are supported, carers are supported, patients are supported in a holistic way. But I think the main aim in looking at all of this for us is making sure we can support and enable patients to improve the experience they have when they contact and seek access from their GP surgery. These graphs are just the numbers presented in a different way. So the first two graphs are showing the rise in appointments and attendances. The bottom graph, unfortunately, has got an upward trend, and this is the did not attend. So it's a failure to attend when appointments were booked. And I think that's a large proportion of what we're trying to work with the public in their experience. So if they're making an appointment but they can't keep that appointment, how do we improve that experience? There's a lot of programmes of work we're looking at, which Hilary's going to cover now. But I think it's key to say, yes, general practice is under pressure, but there is a lot of things we are doing to discuss, identify opportunities. And at the core of this, we must make sure patients understand where they access support and how we just improve their experience in doing so.
Thanks, Pamela. All this is about improving patient experience, and that patient experience is very dear to, I think, everybody who works in primary care. That's what we're there to do. It may seem quite simplistic, but we actually need to fully understand about demand and capacity. Practices collect different data in different ways. There are different clinical systems. And it's understanding what's the capacity in terms of workload, not just the appointments, but all the work that goes around that. What is the demand? Thinking about phone systems, what's the demand that is hidden for people who don't get through? We really need to capture all that. So across the region, there is a collective focus and agreement from primary care networks, the LMC, the ICB, to do some data collection and collect some baseline. For the first time, we were all collecting things in the same way and for the same purpose. And part of that is working with our secondary care colleagues to understand the impact for them and ensuring that patients are seen in the right place, where's best for them to be seen in terms of the care they receive. Is it primary care, secondary care, where is best? Pamela's heavily involved in working on to develop a 5-year delivery plan across the ICB for primary care. And the focus is on primary care, not just general practice. So that is working with colleagues in dentistry, optometry and pharmacy to understand what can be done to improve the patient experience across all those sectors. So there's going to be a focus on the baseline, which will inform the opportunities. And Pamela's also already mentioned about the workforce, the estates and digital. They are all enablers. And also, I think in terms of that clarity for patients, that it's not just about patients being looked after by their GP, but by their primary healthcare team. And that includes nurses, paramedics, physiotherapists, mental health team, clinical pharmacists, wide range of people within a practice who all have skills and abilities, much more experience than perhaps some GPs, and it's about where that patient is best seen. And making contact with the practice, I think all of us were really pleased to see in the contract changes that were announced this week that the dreaded 8 a.m. phone call scramble is going to disappear. And I think that is equally loved by patients as well as reception staff, because when you're on reception and you see all your appointments disappear and you know you have to answer the phone to a patient who understandably is going to be very annoyed that they can't get an appointment, and that is quite difficult. So I think we don't know the details of how that will actually be implemented, but we know that that is going to go. And that is only applies to a few practices in Northumberland. The vast majority operate different systems. So our focus is going to be on there's going to be a national recovery plan. And I find that quite ironic, actually, that this is called a recovery plan in the sense that, as you can see, we're actually providing much more capacity and providing more appointments now than we did before COVID. And it's understanding the baseline on which that recovery is made. Working with colleagues to understand demand and population needs and linked to inequalities and the JSNA. And an example of that recently has been that Health Watch have worked with Well Up North to deliver healthcare services to a group of fishermen in Amble. It's a group of people who traditionally haven't been able to access primary care, and health services have gone to them. And the feedback certainly I've seen, I saw it on TV as well, that that's been very much appreciated and has worked very well. There's going to be focus on increasing and retaining the workforce. How do we stop people leaving, and how do we persuade people to stay? I think for some practices it's a real challenge. When I was speaking to one practice manager last week who says, you know, constantly going past their window is a bus that says Lidl or one of the supermarkets is paying £12 an hour and they get reductions on their supermarket spend. And how can they compete with that in primary care when there's a 2.1% uplift on the contract? So we really need to think about limiting risks to the practices, which are small businesses, and that it's working together, you know, purchasing things collectively. There's been a huge increase in energy bills. So we need to look at how we protect small businesses, how we sustain general practice. Continuity of care is very important, and as Pamela said earlier, there's a huge increase in the number of over 75 population. We know that that group of people will have complex conditions, more than one multiple long-term condition, and for them continuity of care is important, to see the same group of physicians and clinicians looking after them, and that is something that clinicians want as well. That is what they value. We need to look at reducing the administration burden, and also that integration with primary community healthcare team. The 0 to 19 group that's just presented is a good example of that, how we're all integrated and working together. But this is about developing solutions. So how do we ensure that this board has the opportunity to inform this agenda? What can we as a board bring to these conversations? And I think it's important to stress that general practice have always had patients at the centre of the design, and they're constantly changing things, looking how we can improve things for patients, and that is what they're about. And it's looking at facilitating whole system solutions. The solution doesn't just lie with primary care, it lies across a much wider system. Thank you. Any questions?
Thank you very much. It's a very good report. Are there any questions? Yes, Guy, please.
Thank you, Paul. The work at Amble with the fishermen has gone down extremely well. I represent further up the coast at Sea Houses, and if we could see that extend up to all the way up to Berwick in the various fishing ports, that would be excellent. And I've also had discussions with a GP friend of mine in Berwick about extending that to the farming community as well, more so the hill farms. So if you could set up those sort of things at, say, Wooler Mart and Hexham Mart on sale days, I think that would be something that would be really helpful.
That's certainly something we're looking at in terms of providing services at the marts. It was strange that we put on a session, particularly at Bellingham, and we're thinking that farmers would come. And when the session was held, it turned out that several of them were rushing up from Hexham because they were at the mart on that day, and then having their vaccination and rushing back to the mart again. So we need to think more about where are people, where do they need the services.
Thank you for the report. I mean, I think the first thing is it's absolutely fair to say the public do feel that there is an access problem nationally and locally. I think it's worse perhaps in certain areas of the country, but local experience is not where any of us would want it to be. I suppose three points. I think the first is that hospitals, I think, over the last 20 years have evolved significantly in that the care that you receive in hospital is not equated to consultant care. If you look at, we've got 12,000 members of staff across Northumbria. There's about 250 to 300 consultants. And I actually think the term general practice is dead. And I think we need to look at primary care and the primary care teams, because I think too often the link between a GP surgery and the GPs that work within it is not helpful. And I think it's often the case that the skill mix means that you can get better care elsewhere, and we need to look at that, because I think there are still members of the public that feel that if they're not seeing the GP, they're not getting the best care. And I have to say, I don't think that's correct from a clinical perspective. I also think needs to be a realisation. I was just thinking, I spend more a month on my dog's pet insurance than I do for the whole of the family, virtually, for primary care. You're probably spending about £12 to £13 per person per month on the totality of your primary care insurance, for want of a better word. I don't think we realise quite the value that we get, and that's not to say that it is not needing improvement, but it's actually a phenomenally good service for what we invest in it, and I think that's a separate issue. But I think sometimes people are not necessarily aware of quite the financial pressures that are out there that affect recruitment, and I think that we need to a degree, make sure that our primary care colleagues feel supported, because if we get a series of retirements and whatever over the next few years, whatever we do will be marching a rearguard action, and I think it's really important that we retain and recruit into Northumberland not just GPs, but all of the healthcare professionals that we need, because it's easy to see that you get the balance wrong and you end up with deserts where locums and others, which is not giving the continuity of care that our public want, would not be the model that I think we should aspire to.
Barrister, good points. Any more? Yes, David.
Thank you. Healthwatch still receives more queries about GP access than anything else, and it's reassuring that we have plans to continue to improve access, which seems pretty good from the figures there, but in the public mind it's still an issue. So I think there's work to be done convincing the public that changes are afoot to make it even better. But one specific question, if I may. You mentioned in the presentation, Pamela, about the declining number of GP practices. So when there is a GP merger or closure, this does exercise the minds, understandably, within those communities. Now, I remember when such issues were being debated very comprehensively, and it was in the Primary Care Committee. So might I ask, where are those issues discussed now, because they have significant impacts potentially on communities? And within those discussions, do you still go to great pains to listen to the public voice and to respond to the concerns which they inevitably will have when faced with a merger or actual closure of a practice? Thank you.
So yes, with the transition from the CCG to integrated care boards, there has been a change in the structures of meetings and where these things are aired. What we've done in Northumberland is be very conscious that we maintain engagement. So as part of the process of any practice change, we do require them to do a full range of engagement with their local communities. We also still have regular meetings with the Overview and Scrutiny Committee Primary Care Application Working Party, and we also meet with local councillors where we have a potential change of service that might impact a community. So that is very much still at the heart of everything we do. In the transition, the decision making, we do have forums and executive directors within the ICB who support decisions at local level, and we're just moving into a new framework for primary care across the ICB, which will reiterate where those decisions will be made. But transparency of decision making is at the heart of that, because I think we work very closely with the local medical committee from a provider perspective. The Overview and Scrutiny Committee have members on our primary care improving patient experience to access group, which has got some of these projects sitting within it. So engagement is very, it's pivotal to us, because we've come up with some solutions that we may not have considered and understood the importance of. We've got an Air Force base, up the country. We've got farmers. We're different in Northumberland because we've got communities that you wouldn't normally find in the likes of Gateshead or Newcastle or North Tyneside. So understanding the needs is very much at the heart of what we do. And just coming back to the point you made about a focus on change. So the GP contract at the moment requires any patient walking into a surgery must leave with an outcome, either an appointment or signposted to a service. The changes coming in from April is asking all practices to put plans in place that regardless of how a patient contacts the surgery, they leave with the call ends with an output. So they either have an appointment or they're signposted. None of this, as you said, that's kind of the ethos around getting rid of that 8 a.m. call. If they've all gone today, call back tomorrow. So we can't do any of this without the views of the public, of our local councillors and other providers. So engagement is very strong. And I know you in Healthwatch, we look at your reports as well on access to services. We do get a lot of complaints. We do get a lot of compliments at the same time. I think the fact we are offering more appointments in general practice in Northumberland than we ever have, but we're still finding patient experience isn't as satisfactory as it could be, really means that this should stay on the agenda at the top of a priority for a while to come.
So sorry, could I ask, in terms of GP closure or merger, which organisation, board, committee makes that actual decision?
So it's the Integrated Care Board, which inherited the role of the CCGs pre-July 2022, and Northumberland as an ICB, we're an office of the ICB, so the Northumberland arm of the Integrated Care Board, the ICB, still exists, and the team is there. We still have a structure. We have executive directors that link. So the decisions on some elements can be made at place. It just goes alongside our governance arrangements, standard financial instructions that might change where, but we are a single organisation.
Okay, thank you.
During the COVID lockdown, we had the online consultations, the concept of online consultation came. I for one, found that in some cases, very useful, because I'm a diabetic patient. I go there, give my samples physically, of course. And then there is a review session, go through the results and everything. So I found that when it was done online, it was much more convenient for me as well as for the GP. So my question is twofold. Like, is the concept of online consultation with GPs being erased out? And secondly, will it, if we have had online consultation as well as face-to-face consultation, will it improve the access, degree of access to the GPs?
So online consultation, we call it video consultation. Yes, it was very beneficial. I think it was welcomed by patients, not all. Some patients didn't like it, some patients did. And it will still exist in some shape or form because, yes, it offers a range, and it kind of moved us on, didn't it? It brought us into that 21st century from medicine and patients, and it is very useful. However, we just need to get the balance right of what proportion that looks at. But I think also there is a pressure to increase the face-to-face. I think the negative side of the video consultations and the telephone consultations and the other modes of access, they added the demand on top of all of the normal demand, and the turnaround time, they take less time to do, but it's added to just the bigger picture of demand on general practice. I don't know, Graham, if you wanted from a GP perspective to add to that.
So there definitely has not been a conscious decision not to use video consults, and that technology is still available to us. I think what we learned when it was new technology is that it probably doesn't offer a huge extra benefit on top of telephone consultations if we actually would really need to see that person face to face. So it would be my personal opinion that we should do what is right for that patient's clinical care and not create artificial barriers about you must do this first or you must do that first. Interestingly, our ability to get photographs of things online and by text messaging is actually been one of the biggest helps for us. So often we can make an opinion with a phone call to a patient and say, send me a picture of that, and then we can decide whether you need to see me or I need to see you between us. So it's about using the technology to the best from a clinical perspective and actually what's most convenient. The more we can do to avoid unnecessary travel and avoid people coming unnecessarily to see us, as long as everybody is happy and it is safe, the better. Yeah?
That takes us to the forward plan. So we have a meeting, next meeting. Any comments or suggestions on the forward plan? If you do have any later on, please email to me or Jill. There is no urgent business. So with that, I think we can conclude this meeting. The next meeting will be on 13th of April, 2023 at 10 a.m. here. Thank you all for coming. Thank you for your contributions and presentations especially. Thank you very much.